Well, hello and welcome to a Renovo Health podcast. I'm your host, Josh Johnston, along with Steve Vereen. Renovo Health is an independent direct pay surgery, endoscopy, and infusion center offering exceptional patient experience at fair, transparent, bundled prices. We achieve this double objective, exceptional care and dramatic cost savings, by connecting patients and businesses directly to caregivers and thereby avoiding the nightmare that is insurance building. Today, we have a terrific guest, Dr. Brian Woodbridge of Customized Healthcare Services. Dr. Woodbridge is a board certified internist with a long practice history in Northeast Wisconsin. He is a founder of Customized Healthcare Services, or CHCS, as we like to call it. CHCS is an independent provider of primary care to businesses and individuals with a unique approach to healthcare. Brian, thanks for joining us. Welcome to the podcast.
Thanks, Jess. Glad to be here.
Brian, if you could just start by highlighting for the audience how you got into medicine and then kind of how medicine took you to where you are today in your current practice.
I have a very interesting way I got into medicine. As many people know, I was spent the first part of my life as a musician. I was a trumpet player, keyboard player, and taught music for many years. I was teaching at a high school and playing in a couple bands in the Milwaukee area and started kind of getting burnt out as I was putting in 60, 70-hour weeks at the high school. And then every weekend I was playing weddings and bars, and I'm going, I can't keep doing this forever. So I actually looked into getting a different teaching certification. So I wanted to teach something like English or math or something. And then I made a couple phone calls to universities and said, hey, I want to get another teaching certification. Can you help me out here? And they did. They got me in. And so I started working on another teaching certification. I just started taking random courses and math and chemistry and physics. And the next thing I know, I was taking the MCAT, and that's how I got into healthcare and how I got into medicine. It happened very quickly. I wasn't really quite prepared for it. So I ended up, in fact, I don't really even I believed I was going to be a doctor because in medical school I started another band and called the Arrhythmias, and
Nice.
starting writing arrangements for the kids in the medical school, and this thing became really big, became bigger than my medical school, and we ended up playing at the union, playing for all the white coat ceremonies, playing for the dances, and the dean of the medical school kept calling us up to play all the time. And I said, I really should study one of these days. So that's how I got into medical school. It wasn't intentional. I was just looking for another teaching certification. So when I got through it, I did my training at medical school at University of Wisconsin and did my training at Iowa. Like Steve, correct? I think Steve, you're at Iowa. And Josh, I can't remember. You were at Iowa too as well?
I did medical school there.
You did medical school there. And so then after my training, I came to Green Bay because I had some friends here and kind of set up shop here as a hospitalist. And most people in the area know me as a hospitalist. I've been working at multiple area hospitals now for well over 20 years. And so then I start to look at doing outpatient medicine, and that's really how customized healthcare came to be, because I talked to my employer and I said, I'd really like to try my hand at some outpatient medicine. And so they set me up with a clinic, and pretty soon 2 clinics, and then 3 clinics, and started doing outpatient medicine. And that was when I really began to see what everyone was talking about when I would take care of patients in the hospital, and they would talk about how crazy healthcare was getting and how dissatisfied they were with it. And when I got to see it from the other side, from the outpatient side, is when I started to understand what they were telling me. So I am a rare bird that I have an extensive experience on both inpatient and outpatient healthcare. So as that went along, then along the way, I became the medical student director. We started bringing in medical students and became more administration at that point. And then I became the quality director for the North region. And again, began to learn more and more about the flow of money in healthcare. And that's really what opened my eyes to what's going on. So I was watching that happen and saying, gosh, what is going on here with with all these billions of dollars flowing around and everybody's so dissatisfied. My patients are dissatisfied. Well, the outpatient clinic experience for a physician is very, very dissatisfying. And I said, who the heck is going to change any of this? How is this going to, where's this all heading? And this is where my personality kind of starts to get involved. I've always been kind of a get in the weeds kind of guy and try to figure things out and try to find where the problem is, because I would have patients come in that were, they'd be business owners. They say, I can't afford health care for my employees. The employees would come in and say, I can't afford any of this. I can't afford what you're doing. And then I'm looking at all the doctors around me. They're all miserable. And I started thinking, gosh, 30 years ago, you couldn't get an internist to quit. You couldn't get an internist to quit their job. They wanted to work until they were 70 years old. They loved it. They loved their patients. They loved their job. And now people are leaving in their 50s because they just hate it. They just hate their job. And this is all wrong here. So that's what started customized healthcare. As I said, something has got to change here. And I said, why don't I try putting a little side project together and see if I can figure out how to fix healthcare on a small level and just see what I can do. And so that's how I started this, and started networking, started talking with insurance people, because I realized right away I was going to have to learn a ton about insurance, particularly how insurance is bought and sold to large organizations. That's what I really wanted to find out, because to me, that seemed to be where the problem was. So I started looking into that, started getting to know insurance people. And what I found out really quickly is there's no books on this. You really got to learn this stuff by hanging out with these people and finding out what they do, and they kind of tell you how they do it and where it comes from and what their motivations are. And that's when I started to find out that, as everyone in this world finds out, Josh and Steve included, that, the real problem with healthcare is everybody starts confusing insurance with healthcare. And that's the big problem, is that everyone keeps thinking that, well, I've got insurance, that means I have healthcare. And as we're finding out, you can have all the insurance in the world, and that doesn't mean you're getting any healthcare at all. You're just spending a lot of money. And so I kind of got into this world now where I started running into people like Josh and Steve, started running into doctors that were pulling out of the hospital systems and saying, I want to fix things too. I want to try to fix this. What can we do? And you start to realize that what's going to solve the healthcare problem is to get away from this idea that everything has to run through insurance. And if you start reintroducing market-based principles into healthcare, things are going to get better. And it's the concept of just pushing insurance back into an insurance role where it belongs, and then trying to do as much market-based as you can. And market-based means quality and price, like anything. It doesn't matter whether you're talking hamburgers or tires or healthcare. When you reintroduce market-based principles into anything, you're going to start seeing quality and price move in the right direction rather than the wrong direction. So that's what led to customized healthcare. It's just trying to figure out why doctors were so miserable, B, trying to figure out why my patients were miserable, and C, trying to figure out why all these businesses and organizations were miserable and angry, very angry about it. So I don't know, that's how I kind of started with, and it just starts to grow. And that's what I hope we talk about, how we're doing this.
Well, we sincerely congratulate you on your courage in both investigating and trying to find solutions. So it is a rare event in the physician world.
What I have found, I think we all know this, is that physicians tend to be risk averse. That's very common among physicians. They've put a whole lot of effort into their education, a whole lot of money into medical school, and understandably they're risk averse. They want the paycheck coming in, they want the nice house, they want the nice car, and they don't want to step too far out of that mold because they don't want to jeopardize that, and there's nothing wrong with that. But the problem is everybody just keeps complaining. It's getting worse and worse and worse. Someone has to step out and at least try something. And that's why people like Josh and Steve are so important. And because what I realized was that the changes that have to be made have to kind of grow out of the primary care doctor, getting back to this concept of doctor and patient. And that is I hate that phrase, but sacred bond. It's way overused. But the idea that that's what matters is that bond between the patient and the doctor. They trust their doctor and they want their doctor to help make decisions. They want their doctor to help them guide their care. The patient does not care that their doctor knows everything in the world. They do not care that. What they care about is that they trust their doctor and that if he doesn't know something, he's going to help them get to where they need to go. So that's where I started. I said, okay, let's start the clinic. Let's move to a direct pay model, a DPC clinic, fine, if that's what you want to call it. That's where we started. But I wanted to apply the DPC clinic model to large groups. And I said, this is where the magic is going to start happening. So I just kept pushing and pushing to get groups to think about this. And I realized then at that point that the groups would go, well, what about surgery? What about orthopedics? What about cardiology? What are you going to do about all that? And I said, I'm going to fix all that too. So the first gift to us was Green Bay ER and Hospital. Independent emergency room and hospital just dropped out of the sky. I always say it's like I say it's like the Wizard of Oz when the house just comes down, and it just lands here in Green Bay. And they called me up before they even put a building up, and they said, hey, we'd like to associate with you. And I said, that's great. And I said, who the heck told you to put this here? You landed this thing in the middle of Fort Knox. I don't know why you did it, but all I know is I'm glad you're here. So all of a sudden, I have a contract with Green Bay ER, and we have a place now to send our patients for urgent care ER stuff on a contracted basis, not going through insurance. And holy cow, that worked out. And all of a sudden, patients are getting used to going there, and the checks are being written to each other, and it's working, and it's saving not only a whole lot of money, but it's getting people way better emergency room care when they need it. So that was, again, a blessing from God. Well, then along comes these guys named Josh and Steve, and they said, hey, we want to put up this independent surgery center near the big hospital in Two Rivers. And I said, what? And they met. And next thing you know, now I have access to, direct market, GI services and pain management services, and now general surgery. Like I said, there's a reason why this is all coming together. And it's because the need for it is just so overwhelming. People want to get back to a world of quality and price. They don't mind paying money if they know they're getting a good product. Just like when you go to buy tires, you want to walk into a store and say, hey, I want that tire there. That's the tire for my car. It's going to work. I don't need this $1,200 tire. I don't want the $50 tire. I want this good one right here. That's what they want. And, there's a lot of value to that, So I don't know, that help.
Yeah, absolutely. So you mentioned this already, but I want to tee you up so you can say even more about it. So help the audience understand about the value of direct primary care, we'll use that term, or physician guided care, both for employers and patients.
So the core principle, as everyone in this space knows, everyone that leaves the hospital systems and is trying to fix the system, they all realize that the core problem is people keep confusing insurance with healthcare. And anyone that thinks of a bureaucracy as substituting for an actual product starts to realize that you spend $1 on healthcare through the bureaucracy or, through the machine. For every dollar you spend or that's taken out of your paycheck for a healthcare premium, you're lucky if you get 10 cents a care. So the first principle is get back to where you pay your doctor that dollar, and now you're getting $1 of healthcare. You're not getting 10 cents of healthcare. The first principle is by doing that, suddenly patients are like, wow, I don't get 8 minutes with Dr. Woodbridge like I used to at Aurora. Now I get 8 minutes. Now I get, the 45 minutes, and we get to cover everything we want because that dollar is going 90% further by just paying the doctor directly. This is expanded, rather than using insurance to pay for labs. We can do that here in the clinic. We can draw the lab and charge it to insurance. But those prices then go up from $50 or $60 up to $600. Like, well, why would anyone want to do that? So most of our patients are like, well, I'd rather just pay you the $47.57 than run it through insurance and go, I have no idea what I'm going to end up paying for it, because that's what happens when you go through a bureaucracy. So the value on an individual level for individuals and families coming into a, quote, direct primary care clinic or physician care clinic is that they're going to get a lot more health care for their dollar, just way more. You're going to get way more personal attention. You're going to be able to cover a lot more ground in your appointments. There's no longer any barriers to overcome when you see the doctor. It's not like, gosh, I've got diarrhea and I've got a fever, but I don't want to go to the doctor because I don't want to get a $400 bill. So, I'm just going to hold off, well, maybe it's something serious. So now, because you're doing the direct primary care and everything's already paid for, now there's no longer any barriers to coming into the clinic and getting it checked out. There's no longer any barriers to just coming in for a checkup. There's no barriers anymore for minor little stuff. Just come on in. I tell my patients, just come in and talk about fishing. I don't care. While you're here, we'll talk about fishing and I'll update your chart, make sure you're up to date on, on your screenings and all that stuff, and I'll feel better about you and about your care. So that's the individual and family level, is you're just going to get way better care than the big systems under a direct primary care model. On the organizational level, this is where the cost effectiveness and the leverage really starts to play out. Because when you start taking that dollar that 100 employees are being charged, in their premiums for their employee health plan, and now instead of that money going out the window to the hospital systems and the big systems, and you start funneling that money now into a dedicated clinic for that company, a dedicated clinic for that school district, and you start doing that, and now you've got board certified physicians that are helping direct that person. They're not going to the ER when they have a fever. They're coming to you. They're not they're not spending $400 on labs that cost $25. They're not getting $7,000 MRIs that I can get for $700. So all of a sudden, those things add up. One by one, the patients are like, wow, this is really kind of neat. This is really kind of cool. And their employers are supportive of it. So it's just a model that can't lose. It just really can't lose, because it's addressing the fundamental problem that we've got, that everybody thinks you have to run everything through insurance when you don't. You can pay for a lot of this stuff, and you save insurance for when you need it. You save insurance for when you need the bypass surgery. You save the insurance for when you fall and break your hip and you need, that's what insurance is for. It's not supposed to be paying for blood pressure checks and, minor stuff. That's how you end up with $400 aspirins in the hospital,
I love your picture there of getting 10 cents of care out of every dollar in the traditional system. And I think you actually might be generous there. It's probably less than 10 cents, but
I think the latest data that I showed is it's right around 8 cents.
Yeah.
Is optimistic.
Yeah. The data I looked at from, gosh, this was 8-9 years ago, generously, you were getting 15% of the dollars that were taken out on premiums were actually getting spent on anything in healthcare. But that was from, like, I think 20, something like that, data or something. So it's gotten worse,
And I just don't think people realize that. Patients certainly don't realize that. You're so right. They think I've got insurance, so that's paying for healthcare. They have no idea how the income stream works and how the money is pulled out here and there and there and there. And it's all things that don't provide value to the patient, right? And as you just talked about, what the patient cares about is, do you care about them? Do you have time to see them? Do you have the resources to help them or guide them?
Where we went wrong with all of this is there has been a whole lot of regulations and statutes passed over the past 40, 50 years that have really led to where we're at, because what those regulations and statutes did was they crushed independent, medical care, and they kept promoting more and more global hospital system care that kept getting bigger and bigger and bigger and bigger. And that's because the laws were encouraging that sort of thing. And the one, of course, that upsets me the most is primary care has been absolutely crushed. Nobody wants to do independent primary care any longer, and it's almost by design. You come out of medical school residency, you've got hundreds of thousands of dollars in loans. There's no way on earth you can set up a private independent, primary care clinic and expect to get any kind of, patient volume within 5 years. It takes 4 to 5 years to build up a decent practice as a primary care. What are you going to do? You're going to declare bankruptcy before that. So what's going to happen is the hospital system step in and go, hey, we're going to waive these checks at you. Don't worry, we've got you taken care of. So the first thing that happens is everyone's coming out of their training. They're signing on with hospital systems, and from that point forward, you don't learn a thing about the finances of healthcare, the finances of the way the medical systems work. All they want from you is to click boxes in an EHR that you don't even know what happens after you check those boxes. I do now. I didn't know before. Now I do. And you know, they don't want you to know this, because if you really knew what was happening when you were clicking those boxes, you'd be like, oh my God, I can't believe I'm doing this. But that's how it's ended up the way we're at, because hospitals can all practice under one tax ID, and they can self-refer, and they just keep making more and more money off of this, incestuous relationship between all the multi-specialties and the primary care. The primary care is more or less just a referral organism in a healthcare system. That's all it is turned into a referral mechanism. Patient comes in, almost intentionally make the day so awful for you that when the patient gets in front of you, you're just like, oh, they got a heart problem, well, off to the cardiologist. You got a gastro problem, well, off to the gastroenterologist. This is what they do, and that's why they only want you to have a few minutes with each patient, so that you do refer a lot, refer. Now, if you can get the primary care out of the hospital systems, and the primary care begins to be Switzerland, where now you have the time to spend with a patient. You say, hey, what do we need here? Well, do we even really need to go to the hospital? Can we handle this right here in the clinic? Do we even need, to spend $12,000 on a colonoscopy that over here at Renovo Health we can get for a quarter of that? There's all these possibilities open up, but you don't even know of those possibilities when you're under a big system. You don't even know they exist. So the way to attack this problem is, it's tough, because you have to get more and more forward thinkers like Steve and Josh here that say, we want to make a difference. We really want to join this movement. All it takes is for someone that can come and sort of organize it into a functioning group of independents. It's herding cats. It really is herding cats. And that's kind of where I came in. I think that's what I'm doing. Wouldn't you say, Josh? I think that's what I'm trying to do, is herd cats.
Well, you are helping organize them, that's for sure. That's for sure.
Yeah.
So tell us, Brian, a little bit about some of the major frustrations that you encounter as you're trying to educate employers about direct primary care and that process. You've talked about the general public misperception and the patient's misperception. Tell us about, as you engage with employers to try to give them this benefit, to try to help them to control their spend and get their employees healthy and on the job. What are the frustrations that you encounter there? Things that people don't know or don't understand that you think they should?
Yeah, that's a several layer problem. As you're aware, traditionally, and this is what I got to at the very beginning of our conversation. I wanted to find out one of the key findings I wanted to figure out, because this was coming from my patients. They're business owners, they're CEOs, they're CFOs, and they would complain, complain, complain. And I realized that I needed to find out how insurance was bought and sold to systems and how an employee health plan was actually set up. So that's where I began. I started to buddy up to different insurance people. I kind of started to get networked into those groups. And what you started to realize is that 85% of insurance brokers don't even know that an independent world even exists. They do not even know it exists. And then you start to, we can talk about this till the cows come home, but the incentivization with insurance brokers has traditionally been, well, if the employer's, costs go up, the broker makes more money. They actually make more money if the company's health plan is doing poorly. So if it goes up another 10%, well, the broker makes another 10%. If it goes up another 20%, the broker makes another 20%. So there was literally no incentive for brokers to try to institute anything that might help save the company money. They just wanted it to go up and up and up, and that's the way it worked. So that was one obstacle, is probably 85% of brokers don't even know there's an alternative out there. And if there is, they don't even care, because that's not the way they operate. The second obstacle has been human resource directors. Human resource directors, they really have no training in healthcare. What they do is they come out and, they learn about all these different aspects of a company, mainly complaints and job actions and all this kind of stuff. And what happens is the CFO or the CEO kind of dumps healthcare on their lap. Well, to an HR director, this is something that's way too complicated, and they just want easy. They don't want a problem with it. They just want easy. They don't want 45 people calling them up complaining about their new employee health plan. They don't want 45 people calling up and complaining about, I can't get anything I need. They just want it easy. So the oldest saying in the human resource world is, no one's ever going to get fired for installing United Healthcare in your employee health plan. But that might be starting to change, because when the costs keep going up 8, 12, 20, 30, 40% a year, well, now people are starting to think about getting fired for putting in these traditional products. Human resource directors combined with the brokers have sort of been a barrier to these new concepts getting through to the CEO. So there's really been a two-pronged approach by people. My approach has been top down. I try to talk with the CEO, the money people first, because I explain to them how it is that installing high quality primary care right into their company and doing it in a thoughtful way, coordinated way with the broker can save their company just enormous amounts of money and give their employees way better care. So you have to start there and kind of move down to the HR director and kind of get them to buy in, and then that helps. The other approach is the bottom up, and that's where you meet with brokers, getting them to understand what it is you're offering and try to get them to start learning about it. And unfortunately, Steve, you know this. How many times we've talked about this? We're talking maybe 5% of brokers? at the most, maybe 10% of 10% will
Right.
want to learn about it. And then in the end, you're lucky if you get 3% that actually go to a company and say, you need to do this. This is really going to help your company. But going from the bottom up, the broker approach has been the strategy from other organizations. So I'm trying to do top down. Other organizations are trying to do bottom up. Between the two, we're hoping that we start to get somewhere with this. You mentioned the other frustrations. There's books written on this, and what you'll find is that companies have been trying to figure out the healthcare thing because they make hammers, they make engines, they make tubes. This is what companies do. They don't want to know anything about healthcare. But unfortunately, they've been thrust into this world where their costs are going up. It is now the second biggest line item in their company's budget. And they're like, what am I going to do about this? This is costing me more than payroll. It's costing me more than my material to run my company. I have to get involved. So what has happened over the last 20, 30 years is some companies have actually made a big deal about, I'm going to try to solve this on my own. The hospital systems aren't solving this for me. My broker's not solving this for me. I'm going to take it upon myself to solve this for myself. And so what they do is they start contacting independent clinics, independent organizations saying, what will you give me a colonoscopy for? What will you give me this surgery for? What will you give me this for? And they start working out these deals direct to employer. It's a specialty service direct to employer. And the biggest example of this in Wisconsin is Quad Graphics. They were the early innovator on this and trying to do direct to employer contracts with specialist services. And it has been mildly successful. But this has been going on now for 25 years, and it always just never seems to get off the ground. And it's understandable why it never gets off the ground. Because employers make hammers. They make tubes. They don't want to be writing checks for x-rays and labs. They want to get back to doing their business. So this is kind of the big revelation for me is I realized patients don't want their company telling them where to go to get a knee surgery. They don't want their company telling them where to go for, their gallbladder surgery. They want their doctor telling them where to go. That's where the trust thing happens. Is they want the doctor saying, hey, my company has this option. What do you think about it? Is this a trustworthy operation? I mean, are these doctors good? They want your stamp of approval. They want you to say, hey, yeah, this is a good thing, or no, this is not a good thing. I would not go anywhere near that. That's what they want. So it's that trust factor between patient and their primary care doctor. So I said, okay, that's the key here. Get the trustworthy doctor embedded in the company. Now the patient comes through you. Now the company doesn't have to worry about making those referrals anymore. Now the doctor that they hired for their company does that. And I say, yeah, this Renovo Health thing is fantastic. It's like, I can tell you right now that the people that are working out of that ASC are big hospital system that got frustrated and they can't take it anymore. And now they're looking to have a decent life now too. And so guess what? Those are oftentimes the best doctors. They're the best physicians. And they've broken off now and they're trying to find places like Josh and Steve where they can work and they can, get things done and actually have a real relationship with the patient. So the frustrations that I've come across with employers are human resources just doesn't want to make any change because they don't want headaches. The brokers are disincentivized to do the right thing. It really takes a special broker to do this. And C would be these direct to employer arrangements can oftentimes just never really get off the ground because there's just nobody guiding the care. There's nobody guiding people here, nobody guiding people there. That's where we come in.
To the role of primary care again.
Yeah. Yeah. under an independent model, not under the Death Star.
Yes. Yes. Very good. Um, well, we've been going for a while here, so I'll start to try to wrap it up a little bit. But Steve, do you have other questions you want to ask? I could go on like this actually all night because you're such a wealth of information, Brian. So it's very interesting to hear about your experience and the work you're doing and the frustrations, etc. So,
I was just going to say, I know we've had these conversations multiple times, and I still appreciate the passion and all the energy and motivation that goes behind it. One thing that you've talked about a fair number of times, and I think it couldn't be more true, is your role of kind of quarterbacking things, taking a look and accepting the responsibility, and that's been something that's been so helpful for us as we've looked at the patients we've cared for over the last 2 years. We have different areas that patients get referred to us from. And the DPC model, your group, you and your partners have been leaders from the start. And we're the model that, is kind of perfectly set up for that, just like you're the model perfectly set up for us. But it goes beyond that because there's nobody else that's willing to be accountable in healthcare. That's what we want to do. We want to be transparent and accountable. And somebody has to make those decisions. And that's exactly what you do. You're transparent and accountable. And that's what gets companies honestly off the hook, right? I mean, they can spend less, they can be reassured in what they're doing for their employees, which are the most valuable part of their entire company. And the patients, the employees, the covered lives, however you want to go ahead and put the name on them. I mean, they're all of those things. And to have you in their corner as their advocate, finding these options is really, I won't say priceless because there's a very absolute price we could put on it, and it's uh, uh, monumental, right? It's quite a bit. So I really appreciate you taking the time to share this with everyone else. I've gone through this multiple times. Josh has gone through this multiple times with you, and it is never not exciting,
Yeah.
right?
I think some of this excitement I have for this kind of comes from my music background. I kind of feel like I don't know how to describe it. I feel like I'm directing a band in a way, and you've got the trumpets and the saxophones and the flutes, and each section is kind of like a different piece of the healthcare continuum, and I'm starting to get these people to play together now. They haven't played together in decades, and I'm getting them back to forming a band, back to forming a symphony where they're playing together. They're different, the flutes are different than the trombones, they're different from the baritones, but they're starting to play together. And that's what I kind of feel like when I'm putting all these pieces together. And this thing just keeps getting bigger. I mean, I have more and more people calling, how can I be a part of this? How can I get into your network? How can we work together as independents, where I maintain my independence, and you maintain your independence. And yet what we're all offering is quality care. And I go, that's it. I said, it's just, you do a good job. What I want when I send you a patient is I want good documentation. I want you to tell me what you're doing with the patient. I want you to give me a fair price on your services, to show me what can you do it for? And everybody's happy again because it's because that's the way the world works. Everybody wants to be judged on the quality of their care. Not on how many clicks they can do on the EHR.
Right.
accessories to a bill.
Yeah, exactly. That's all it is.
Well, leave it to you after the Badger and Packer seasons finishing like they did to stop referring to yourself as a quarterback and now as the conductor. Well
Yeah.
played. Well played.
Right.
Good adjustment.
Right. No, it really is what it is. It's fun. I'm actually having fun building it. But I understand the money concerns, and this. If there's anything I want to end with in this conversation, I mean, there's a little bit of selfishness here because I'm saying, look, it's wonderful what we're doing and trying to restore quality and price to healthcare, but I said none of this is going to go anywhere unless the primary care provider starts getting paid again like they used to, that starts getting, a quality, respectable income, this movement has to result in that. If it doesn't, I'm never going to get the best primary care docs out of the hospital systems. I have to have a job to put them in. I have to say, hey, come over here. This is a great job. Our life is wonderful. I finish the day happy, proud of the work I've done, and I'm getting paid well. That's what people want. If I say, well, come over here and you're basically going to, you're doing this to better the world, well, that isn't going to work. We got to be able to pay people in this model. So that's one of the reasons why I'm working so hard at it, because I want to build a world that's financially sustainable, because that's what's going to make it take off.
Excellent. Well, you want to give a last value proposition to people to understand what CHCS does for employers and individuals, and then we'll wrap it up.
The best phrase that I like to use is physician guided care. It's not that I don't admire direct primary care clinics, DPC. It's that when you really boil down what we are doing, it's physician guided care on three main levels. You're helping to guide care on the individual level, on what you're going to do, with you and your family, and, what we're doing right here in the clinic. The second level is helping to direct patients, helping to guide them towards, all of the necessary stuff we do in healthcare, all the labs and the x-rays and the CAT scans and the ultrasounds and all that stuff. Where can we get good value for those services that are, part of the bread and butter of medicine? So we're guiding them towards those things. And then the final layer is the physician-guided care towards when you need specialists, when you need surgeries, when you need this. Where can we find high quality, fairly priced medical services on the specialty market that, we can't always avoid the hospital systems, but a whole lot of times, man, there are some really good independent centers out there that you can send people to. And the patients love it. They go, I got such great care. They took such great care of me. And now you get everything running. Now you got all the pieces of the puzzle working, and now you just have to grow it. So yeah, I would say the prime goal of customized healthcare services is just really good quality physician guided care where we can guide things on a lot of levels. And guess what? When you do quality, the prices come down.
Well, thanks for your time, Brian. And for our audience, as a reminder, we've been talking with Dr. Brian Woodbridge of Customized Healthcare Services, and this is a Renovo Health podcast.